Now about the Chivate proctoscope. Sir himself invented this Chivate proctoscope. Initially it was made by the steel. This proctoscope is available with the local companies. This Chivate proctoscope is made in such a way that it has a blunted tip, then half working space because there is a split inside. Third, there is a space of giving a light source, so the surgical field becomes brighten, and it is 11 centimeter long and 3.6 inch circular in diameter. So it is made in such a way that after taking a double interlocking also it maintains a normal cavity of anal canal. Okay. Now how to insert the Chivate proctoscope? First, do not force to insert the Chivate proctoscope. Okay. Now further, I forgotten about another thing about the scope. Initially, it was made by the Chivate sir himself with the SS material. Then after, he made with the autoclavable transparent material, and nowadays it is further improved with this same transparent material. In this material, what sir has done, that initially SS proctoscope, there was a slit. The scope is like this. There was a slit like this. We have to pull this slit for the working field, and this slit is important to protect the pile mass while taking the suture. Then nowadays sir has made in such a way that the scope is remain same, but the distal part is it is a closed one. There won't be a slit in approximately 4 centimeter distal of the scope. So itself it protects pile mass, as well as by accidentally we are not taking the suture over the dentate line. Otherwise everything remains same. This transparent Chivate proctoscope is autoclavable and it is available in a market. Now, after inserting the Chivate scope, either new one or the previously SS one, you have to be vigilant about your suture site. Chivate sir has advocated the 2 centimeter above the dentate line, but you may vary up and downs according to your need. There won't be that much deviation of principle in taking a suture 1 or 2 centimeter above or the below. This discussion was made with the Dr. Chivate sir himself. I also asked about that, sir, after taking starting the suture line, while I coming back, there was some deviation. Then also sir said, is it okay? Because our aim is to control collaterals at the 2 level, and it should be above the dentate line. So the principle is not deviated while taking or deviating some level of the suture, starting or a level of the suture line. Now, from where you have to start the suturing? 3 o'clock, 9 o'clock, 6 o'clock or 12 o'clock. It's your choice. But in a Chivate surgery, I am using starting with the 6 o'clock position only. How to start with the suturing? I am using two type of needle. One is 27 mm 5 circle 20 vicryl suture. First thing. Second thing, I am using 30 mm needle, 30 round body needle 20 vicryl. Now, you can ask me or I'll tell you why there is a two type of needle coming in the picture and what are the advantage of both the different type of needle. Okay, first, Chivate sir himself was using 30 mm needle vicryl 20. These 20 normally available suture material are the 90 centimeter long. Sometimes on initial days of practice, this length 90 centimeter length may be a some person technically somewhat difficult, but it is not impossible. So don't worry. Now, what about the 30 mm needle? This 30 mm needle are very useful while taking a suture bite when there is a redutant or lax mucosa, and while you are using 27 mm 5th curved needle, it is somewhat difficult or somewhat to pierce lax mucosa. So there is, whenever there is a lax mucosa I found, I am using a 30 mm needle. Then what is a disadvantage of this 30 mm needle? Disadvantage of 30 mm needle, because of its curved, larger curve, it takes a larger bite, and while pulling this knot, there may be some oozing and some tear of mucosa. While the 27 mm needle is mainly first invented by Dr. Ladukar sir. He is very much, and he is doing I think India's one of the largest Chivate procedure, and he is very close to the Chivate sir himself. Then he invented this suture material 27 mm needle with the 100 centimeter, and it is available with the Suture India company with the code LDL, Laxmikant Ladukar. Now this 27 mm needle is very useful to take a smaller bite. So while pulling after interlocking, it gives some less trauma to the mucosa. Because of the larger 100 centimeter length of thread, while coming back at the end of suture, you will have enough suture material in hand to tie. As well as it gives a wrist movement, because it is a 3-8-5-8 circle. So very easy to move, and when you are piercing, and it comes very easily outside. So 27 mm needle is also coming in the picture for the Chivate procedure. But I said you that in a lax mucosa I am getting some difficulty for piercing with this 27 mm needle. Now it's your choice how to deal with the 30 mm needle or the 27 mm needle. Both are there. There is a slight difference of use in between these two suture material, but there won't be anything major change about the principle. Many conferences, many people, or even Lakshmikant sir also using 27 needle in front of the Chivate sir. He never opposed about using a 27 needle, but Chivate sir himself was using 30 needle, and myself love to use 30 needle because of the good piercing principle. So after taking this suture, you have to illuminate the scope inside with your normal light source, which we are using in a laparoscopy surgery. So the vision will be very good. Okay. Now how to start? You take a deep bite, mucosa, mucosa, submucosa, and even the wall also. Don't worry. Take a deep bite and make a knot. Please keep a non-needle end somewhat long while coming back at the end of the suture. It will help. So do not take a smaller one. Okay. After you do the 2 to 3 knot, you start encircling the suture, Chivate suture. Now, you use a curved needle holder whenever it is possible, feasible. Then, after taking a knot, you grasp the thread in your hand. Take a needle holder and see where is the previous bite. Just about that bite or nearby, you have to pierce the needle, mucosa, submucosa, and come out. Till that, it is better to hold the thread. Then pull the needle outside the mucosa. Now you will have a loop and you will have a handle on the right hand. Then with this needle you have to insert in this loop twice. One time, 2 times. Then hold left hand and left hand with the needle, then the pull. Then grasp near the knot, take a needle holder, open the blade and put over this close knot. Do not push, just keep open blade and then pull. See, this pulling is very important. I advocate you that without pulling, there won't be a local ischemia, distal ischemia. That's what we need. If we are not pulling well, if we are not tiring, then collateral will not be ligated. So the blood flow will remain continue. So there is a ligation of that blood flow. So it should be a nearby, not too tight or not too loose. Okay. Now further you hang your thread in the left hand. Take a bite just previous one, pierce the needle and further take out the needle. Needle in your right hand, loop 1 and loop 2. Then grasp a needle, pull the thread somewhat, use further needle holder to further pull the knot for adequate tightening. On initial practice, because of I was using this needle holder while fixing the blade and it was cut. So you should keep open this needle and try to avoid the friction between the thread and the needle holder. Okay, so that's why this way you have to complete the first circle, then distal one. Some people may asking, sir, can we take a first distal one or then the proximal one? It's your choice. It's upon you only. There won't be any problem. Okay. So but my practice is I am happy and I am experienced with the starting proximally. Then I am going distal suture line. Now, while during many people are asking, if our needle is going too much deep, then what happens? See, mucosa and submucosa, after that there will be a sphincter fiber. There won't be that much problem. There won't be any major vessels which is running very near to the anal, our suture line position. So don't worry about any vascular entrapment or neurovascular entrapment. Okay, the peroperatively you may have some oozing for the bite, as well as while pulling you may have some oozing which will stop itself. Sometimes you may injure pile pedicle or larger pile mass. Sometimes it happens. Then what to do? You further encircle, you take a second knot at the same side and it will be stopped. You have to give some the pressure over the bleeding point also. Okay. This is about the peroperative complication of oozing and bleeding, which is very less and it is a self-limiting and it can be controlled by the simple experience of general surgeon. So don't worry about this peroperative bleeding. So after taking the two suture, I am adding the completion of the surgery by putting the ab gel inside. It is your choice. It is required or not. It is upon you. But I am applying the ab gel to prevent that oozing. But there is no need of putting any gauze piece or anything else for the pressure. You can do the diclofenac suppository. That is your choice. It is nothing wrong in putting the analgesic per anal suppository. But for the ab gel, it's your choice. But I am putting the ab gel to prevent the oozing. Immediately peroperatively, the old pile mass are not visualized, which was visualized before the surgery. This Chivate procedure can be done for the second degree bleeding piles, third degree piles, even the fourth degree piles also. The result may be the vary one. I am not going that discussion about its result at present now. We will discuss later on. Okay. So after completing, you just put simple gauze of betadine shock or xylocaine shock over the anal, and there won't be any much more pressure dressing is required. After the surgery, post-operatively, I recommended the IV antibiotic, analgesic as well as stool softener. Now, the post-operative complication. There won't be any major complication of bleeding or anything else. Yes, sometimes it is bleeding is there. It will be a self-limiting. There will be some burning pain because of the instrumentation, and the most common complication is obstructive defecation. That means patient is feeling that a patient is not able to pass a stool because of the lax mucosa. Now it is becomes a fix, and patient is not this mucosa is not allowing the stool go down. In early post-operative days, like on 3 weeks or on yes 10 to 30 second week to third week, there will be some mild stricture on the PR examination at the site of the suture line. But this some obstruction, it will be resolved after a few days. Now, Most important part now coming is the about the result. In India, lots of surgeon and lots of surgeries with the Chivate procedure are now going on. The advantage is it is a painless surgery because we are doing the above the dentate line. Second, it is less costly because we are not using any suture material other than two suture material. Okay. Now the third, because it is a painless surgery, then we do not require any long-term hospitalization. The fourth one, we are not cutting, so that's why the healing rate of the patient and comfort is quite okay, fine. Now, what are the complication? Is there any grave complication about the life-threatening complication? No, I have not seen in my since I am doing since many years. I have not seen or I have not heard about the life-threatening complication after the Chivate procedure. There may be a bleeding, there may be a oozing, there may be a obstructive defecation syndrome, or there may be a recurrence one. These are the problem may be occurred. Now about my experience. Okay, see, first thing, many or almost every the surgeon who are doing the Chivate procedure are very much happy and confident about the result and outcome and the satisfaction of the patient. So I am talking about the other person. Now what about me? Before giving this answer, I am just want to say I am doing the Chivate procedure. I was doing a lot of Chivate procedure. It is the research publication. It was discussed with the Chivate sir himself, and this is a educational video. This is my experience only. I am not giving any data about the other or any evidence base. This is only the clinical post-operative follow-up result only. So now about my experience. See, I was doing a Chivate procedure a lot because of fear of MIPH complication. But with the Chivate procedure, my recurrence rate is too high. That means on follow-up for third, fourth or sixth month, there is a persistent pile mass are there. These pile mass are remain. So as well as after the dissolving the VIPUL suture material, the prolapse are reappears. So patients are coming back to me about the prolapse, persistent prolapse. On initial 2 to 3 years, this pile mass remains non-bleeded. I have discussed about this thing about the Chivate sir that I have a persistent pile mass. Then sir said it is a pathological disease and we should think about the bleeding. So the pile mass is regression is not a problem, but we are giving the symptomatic bleeding relief. But my patient coming back after 3 to 4 years of the Chivate procedure having a remnant non-regressive pile mass with the bleeding also. So my experience regarding regression of pile mass and reappearance of bleeding is not a good. This is my experience only. I may be the wrong one, as well as I may not be the good surgical technician of Chivate procedure. It may be a possible. So this is my result only. Why this may happen? In my case, I thought that ligation is not adequate. That means the force of ligation may not be that much adequate, which shrinks the pile mass because of the local ischemia. This may be the reason one. Second thing, about the comfort of the patient. While the patients remain admitted in the hospital or an initial follow-up of 6 to 7 or up to the 2 weeks, they are feeling very much good about the painless surgery. But after the 3rd week, when the patient is not coming back to us, they are feeling somewhat defecation problem because of the obstructive condition of that 2 suture line. This 2 suture line becomes a somewhat fibrotic, as well as mucosa becomes a somewhat narrow at this 2 suture line. So the dissatisfaction ratio is increasing after the 3 week of the surgery, and this may last up to the next 6 to 8 weeks till the suture material becomes a dissolve. Third thing, in my case, there is a smile oozing from the perineal while passing a stool because of the inflammatory condition of the suture knot inside the mucosa. Now, what I am doing after the surgery? So after the surgery, sometimes this many patients coming back, I have to go for the some resurgery with the other procedure also. This is my experience, and this I have to do in many cases. In short, if patient's affordability is an issue, in compared to if we are talking about the hemorrhoidectomy versus Chivate proctoscope or Chivate surgery, or about the MIPH. Now, if we are comparing with the hemorrhoidectomy by the Milligan-Morgan, the Chivate itself a painless surgery, but the appearance of pile mass and bleeding, patients are not accepting well. And it is very much a traumatic on long-term follow-up with the surgeon that you have not done. Patient is saying that you have not done your job adequately, and these pile mass are coming back to me. Hemorrhoidectomy is a painless, but it is a gold standard till now, and it giving the 100% regression of pile mass. So if we are talking about the regression of pile mass, then the Milligan-Morgan is far better over the Chivate procedure. But in compared to, if you are looking for the 2nd degree piles, then it is a painless surgery. Chivate procedure is definitely a painless surgery over the hemorrhoidectomy. Then, about the circumferential prolapsing miles, the hemorrhoidectomy is nearby the contraindicated, 100% contraindicated, while Chivate procedure definitely gives a good result. Now, if you are comparing with the MIPH, if the affordability issue is not a problem, then we can compare these two techniques about their result. Because we have to use a stapler, but in India we are considering this financial issue as a practice. But on the result, while you are comparing, if you are believing the ligation, then you should go with the Chivate procedure. If you are believing the cutting, then you should go with the Longo procedure or the MIPH. Both the technique are above the dentate line, so it is a painless. Both the technique having a bleeding problem posteriorly. It is a painful in many cases, not in everyone. It is painful. Even a Chivate procedure also is slightly painful in many cases because of inflammation of the suture and instrumentation, while the MIPH also become a painful when because of the staple line. MIPH may have a life-threatening complication if it is not done properly, while the risk of life-threatening complication is very less in a Chivate procedure. That is a reality. But about the evacuation, that means the prolapse. I said in my previous video that piles is a symptoms of rectal prolapse. That means the internal mucosal prolapse is the main issue. We have to deal that part. Otherwise, evacuation of the stool remains a difficult one. So, in a Chivate surgery, we are fixing the mucosa to straighten out the anal redundant mucosa to give the easy evacuation. But after the dissolving of this mucosa, this suture material, the redundant mucosa further come back and stool has to pass out this redundant mucosa to become evacuated. Now, in a MIPH, there is a excision of extra redundant mucosa. So, there is a straight mucosal area in a lower anal canal. So if patient having only the redundant mucosa in a lower anal canal, then he feel better about the evacuation after the MIPH procedure. So this is my choice, my result only. I am not pointing out anyone or anybody, but this is my result. So please bear me, please forgive me, because this is an open channel, and this is I further thing. I have done the research, but I have not published any data about the Chivate procedures outcome. I am nearby, I am preparing the data, and definitely in a coming future, I may able to publish this paper also. Till that, this is only the personal experience. So if you want to ask me about the evidence, I am not able to give this answer, but this is my experience about the Chivate procedure for the piles one. Thank you very much.